Hi, everyone, and welcome to the PedsCrit podcast. My name is Zach Hodges. I'm a current pediatric ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin. I'm a critical care fellow at Children's National in Washington, D.C.
So, Alice, what are we talking about today?
So today we have the second half of a two-part conversation that my friend Shefali and I recorded for PedsAdmit, our resident primer podcast. In this episode, we are going to go right into sort of a PICU primer for residents by system. We love the conversation so much that we couldn't keep it only on the PedsAdmit feed, and so that's why it's here.
Fantastic. Let's get right to the content.
Chloride is the devil's ion, and there's a lot of chloride in normal saline.
Hi, this is Alice.
Hi, I'm Shefali.
And you're listening to PedsAdmit.
Alice, we are back for the next part of our episode with Dr. Ashley Siems, where we are just doing a deep dive into the nuts and bolts of how to present in the PICU, a detailed systems-based breakdown of how to do that. Things I wish I had known before.
Yes, Ashley Siems was the director of education in the ICU in D.C. for many years. Now she's the fellowship director at Johns Hopkins All Children's Hospital in St. Petersburg, Florida.
We're so lucky to have her back for part 2. Let's get started.
I love that you're taking a water break. I was like,
I'm taking a water break. Sorry.
No, we know this is a lot.
Speaking of taking a water break, let's dive into FENGI.
Let's start by kind of broadly breaking down, because I feel like this covers a lot of things, but maintenance fluid requirements, electrolyte management, which is definitely something we do a lot of in the ICU, and then feeds when patients are ready to initiate feeds or when they're on feeds versus GI prophylaxis, bowel regimens, things like that. Is that generally what you see as FENGI in the PICU?
Yes, that is exactly what I see as FENGI. And I had to take a break because I'm just going to put it out there. Bowel regimens are my least favorite thing to talk about. Let me tell you.
That is.
Yeah, same.
You don't like a discussion,
but
conversation?
Also so important. It's like very important, right? Like it's not, yeah.
It is important, but I'm just going to tell you, it is incredibly hard to kill someone with a bowel regimen.
Yeah.
So as a resident, feel empowered to make a bowel regimen and just say, I'm doing this with my bowel regimen.
Just do it.
Just do it.
Area of autonomy on most services.
Yes, exactly.
Go nuts.
So go nuts with your bowel regimen. Just own it. This comes from a DC resident. I didn't come up with this, but you often need a pusher and a musher. So pick a pusher, pick a musher, and go with it.
I love that. Oh.
And also, Colace usually does nothing. So
yeah.
So just know that. Just say Colace does nothing. I'm going to do some Senna and some Miralax, Senna and Lactulose. You choose. Your dealer's choice, you choose, but have a pusher and a musher and you're good to go.
Yeah.
All right. So we got the bowel regimen done. Most kids in the ICU need a bowel regimen. Critical illness causes an ileus, and so they need help getting things along. Complex kids need a bowel regimen. Like you said, it is important. It's just not something that we need to spend a lot of time talking about. So with that, I'll move on to fluids, electrolytes, and nutrition, which is where the meat and bones of this is. Yes. So let's talk about fluids first. So the 4-2-1 rule, by the time you finish intern year, you should be an expert at the 4-2-1 rule. Here's the thing about the ICU. Fluid overload is real. It's associated with increased morbidity and increased mortality. We hate fluid in the ICU. We hate it, but we love it. So one thing to note is that one of the ways you can prevent fluid overload from occurring in your critically ill patient is by limiting the amount of fluid that they have in. So you calculate your 4-2-1 rule, you calculate what maintenance is, and you put them at 2/3 to 3/4 maintenance. And you can do that, and you can justify that by saying, I want to fluid restrict them because I think they're getting fluid overloaded. They got 3 liters of LR or normal saline or whatever. I think they're getting fluid overloaded. I'd like to do 3/4 maintenance. This way I can avoid maybe using diuretics in the future. You're always going to start the diuretics, let's be honest. Eventually. But it means you'll need less diuretics if you're putting less in. As far as fluid selection, I'm a big LR stan. I love LR. It is a more balanced solution, but this is one of those things. You're going to see different attendings do different things. In our neuro population, again, going back to how the systems are interlinked, you want your sodiums to sit higher. And so having a higher sodium content fluid makes sense. Most of our kids get started on D5NS regardless of age. I would say if you're not a neuro kid, consider doing D5LR. Yeah, D5LR is your maintenance fluids. It's a great fluid. Chloride is the devil's ion, and there's a lot of chloride in normal saline.
That's amazing.
That might be my favorite. Is that my favorite one of the whole episode?
We're starting the episode with that. That's the one. I think that could be a t-shirt if you're that's a part of an LR propaganda thing. We don't use LR enough. That's the problem.
Listen, my residents we're like, yeah, I put them on D5 LR. How can you argue? It's the right choice.
It's the right choice.
It's a little different. It's the right choice. So
it's the right choice in so many ways. Like it has lower chloride. It has a little acetate, and all of our kids are acidotic, so you're buffering their acidosis a little bit. You've got a little calcium, which is a good inotrope. You've got a little potassium. It's getting good. Who knew FEN could be so juicy, guys? Pun intended. Yeah. You can tell we've been at this for a while. The delirium is sinking in. So anyway, LR is always the right choice when you're on with me. But since you're not always going to be on with me, there are some people who prefer D5NS. And I would say in our neuro population, NS is the way to go because you want your sodiums to sit higher. So that's pretty much a good way to go is, again, with your fluids, assessing your fluid balance. Are you headed towards overload? Limiting your fluid intake is always a good place to be. But there are certainly kids who are first presenting to the ICU who might be fluid down. So kids in respiratory distress, again, going back, all the systems are interconnected. If you have a kid in respiratory distress who's been febrile, they have a ton of insensible losses. So they might be fluid behind. So it might not be on day one that you want to fluid restrict them. Maybe that's on day 2 of your plan. When you've recovered them a little bit. And so then, that's how I kind of think about fluids. Do they need 3/4 maintenance, a fluid bolus, knowing where you are in your fluid status, and knowing what fluids to pick is always a good conversation to have. The second part of that is, do you need diuresis? So let's say you're fluid overloaded. At what point do you need diuresis? And this is going to be different. This is, again, the art and science of medicine. This is definitely a gray zone. I have rules of critical care. Rule number 2 is that dry lungs are happy lungs. And so oftentimes if you have respiratory failure, you're going to be starting diuretics a little bit earlier. If you have heart failure, you're going to be using diuretics a little bit earlier. If you have kidney failure, you might be using diuresis to help boost your kidney output. So diuretics are used a lot of the time. And I feel like that's a good segue because that leads us into electrolytes. What electrolytes do you care about? What electrolytes are important? So in a seizing patient, you always want to know your sodium, your glucose, and your calcium, because those are the things that can, when they go awry, can cause seizures. As far as replacements are concerned, I think the primary electrolyte you will be replacing is potassium, most likely because you're diuresing a patient. And most diuretics cause potassium wasting. And so you can replace potassium 0.5 to 1 MEQ per kilo. And basically it's like where you are. If you're in the 3 to 3.5 range, you would replace 0.5 milliequivalents per kilo. If you're less than 3, you would go 1 milliequivalent per kilo. And just be mindful that is only replace potassium in a patient who is peeing, because hypokalemia is rarely lethal. Hyperkalemia is always lethal. And so just be very mindful, treat potassium with a little bit of respect, even though we do it so often that we often take it for granted. So potassium is one that you're replacing. I have found that different ICU providers replace electrolytes at different levels. This is not something that's standardized. Potassium is pretty standard. I would say those are good rules of thumb. I would also say that calcium, because it is an inotrope, is one that we try to optimize as well. But again, I've seen people use different standards for this. My personal practice is to follow ICALs, so ionized calciums. And in bigger kids, I use an ICAL greater than 1 as my standard for replacement. In infants, I try to keep my ICALs greater than 1.1. And the reason is because infants, their sarcomeres are not fully developed. When was the last time you thought about a sarcomere?
It's been a
Alice was the other day, I'm sure.
Not for me.
Nope.
It's been a minute.
Yeah. So infants, their sarcomeres aren't fully developed, and so they cannot store calcium as well. So their intracellular calcium content is a little bit lower, and they're more dependent on ionized calcium from the blood to contract. So for infants, you're going to need a slightly higher ICAL in order to maintain your contractility. And so those are usually my thresholds for calcium. And then phos is another big one. Phosphorus is the energy of the cells, right? It makes ATP. In general, I find that children tolerate low phos levels fairly well. When there was a national phosphorus shortage a couple of years ago, we found that you didn't truly have to replace in most children unless they were less than 1.5. That being said, our threshold for replacement, now that there's not a national shortage, is a little bit higher than that and is probably both attending and institution specific. But a phos of 1.5 is definitely a critical value and should be replaced immediately. You have to be careful when you're replacing phosphorus. This is, again, I'm not a nephrologist. The kidneys are smarter than me, and every nephrologist I've ever met is smarter than me too. So this is probably a different talk, but replacing phosphorus is an art. You want to make sure that your calcium is optimized before you replace your phosphorus, because phosphorus will bind calcium and will drop your calcium levels, and the heart doesn't like it when your calcium levels drop, so make sure your calcium is a normal level. And then, again, they're all interconnected. You will stay hypokalemic if you're hypomagnesemic. So we often replace magnesium because otherwise you won't be able to maintain your potassium. And so those are some pearls about electrolytes and the common ones that we deal with in the ICU. Nice. Questions about electrolytes?
No, that's great.
No questions.
Okay.
Yeah.
Good.
When you said the potassium sentence, I see the order in my mind. Like I can just see the PRN order. It's very common.
Because it's so common. You guys are going to, if you haven't been in the ICU yet, you're going to get so tired of your potassium phone calls that you're going to get from your nurses. The potassium phone call in the ICU is the same as your Tylenol phone call on the floor.
Yeah.
Can you just put that Tylenol order in for me? Can you just put that potassium order for me? And it's every patient. Yeah. Shall we talk a little bit about nutrition?
Yes.
Okay. Feed the babies. Feed them all and feed them early. Better to use the gut than not. I think we under-recognize the immune function that the gut serves. Tons of literature out there that early enteral nutrition helps outcomes. That being said, there are some patients that you might not feel safe using the gut yet. So anyone that you're concerned is not perfusing the gut, it is one of the first organs to get shunted away from. Blood is shunted away from the GI tract in order to protect other organs. So if you're afraid that the GI tract is not being well perfused, then that might be a good reason not to feed. There is lots of data out there that it's safe to feed neurologically normal children on high-flow nasal cannula. So don't let anyone tell you you can't feed on nasal cannula. Although there are some physicians who are stuck in their ways and won't do that. So this is another thing that, be mindful that your attendings have certain styles, and they probably have that style because of experience or exposure or cases that have taught them to be that way. But if you look at the literature, it says it's safe to feed on high flow. It's safe to feed early, even when you're on vasoactives. Enteral nutrition is good. And I think that's all I'll say about nutrition. Unless you have questions.
I like that I have a dietitian who's around, because I think that in the whole, grand scheme of critical illness, it does get overlooked or kind of marginalized a little bit. So it's always good to pay special attention to it.
It's true. I do want to say a couple of things about heme. I think a lot of the other organ systems gets very specific. Like obviously you have a patient in DKA, you're going to be talking about about your endo system more often, but I don't think like we need to do a deeper dive for this 10,000 foot view on that. But heme, I think, is an important topic to talk about. There is good literature to say that you can use a conservative transfusion strategy, that you don't need to transfuse unless your hemoglobin is less than 7. So just keep that in mind. Yes, obviously, if you're actively bleeding, you don't want to wait until you get there.
Right.
Because maybe you were at 13 and you're at 10, and if you have signs of active bleeding, you're just going to want to give the blood products.
Yeah.
But in that kid who's been in the ICU for days to weeks, they probably do have critical care anemia and decreased EPO production and all the things, and multiple lab draws. And so you'll start to see their hemoglobin drift down 9, 8.5, 8.0, 7.6. And really the threshold that you can use is keeping your hemoglobin greater than 7. Is beneficial. So that's what I would say about heme. As far as ID is concerned, one of the bread and butters of critical care is sepsis, right? Sepsis and septic shock. And so while we always want to be good antimicrobial stewards, we also have to be mindful that not treating an infection can be fatal. And so we do use very generous administration of antibiotics in the ICU, and we try to be mindful of it and not overuse our antibiotics. For a typical rollout sepsis, you can start with ceftriaxone, add vancomycin if you have concerns for MRSA, broaden the ceftriaxone to cefepime if there's a reason to think that they have resistant organisms or Pseudomonas. And that's really a good standard approach. Those are really good entry drugs, ceftriaxone and vanco, with a broadening to cefepime if you're concerned about Pseudomonas or some type of resistant organism. And so just starting there is a good starting point. Good drugs for the GI tract are meropenem, although that's usually you have to talk to ID to get that. Flagyl is a good GI tract medication if you're thinking that organ system's involved. And I would just also say, always be mindful of your kidneys. We tend to beat up our kidneys in the ICU. So if you don't have to add the vancomycin, try to hold off on it. If you don't have to do Zosyn and vancomycin at the same time, try to avoid that, because that's a very nephrotoxic combination in particular. Just being mindful that everything we do has negative downstream effects, and the kidneys are one of the organs that we hurt the most. It's so reliable. It's so durable.
Yes.
I know. Our poor kidneys. Let's circle back to access. I think that this can either be the first thing or the last thing you address in presentations. I prefer to talk about this up front because it does affect the rest of your plan in some ways. I mean, in terms of therapies that you can give, what's going through what line, but I know that there's different conventions. When is the preferred time to talk about access for you? And then let's just spend a moment talking about the different types of lines in the ICU.
Yeah, I think that's great. I don't think there's a right or a wrong time. A lot of institutions might have it standardized as far as when you talk about it. I do think bringing it up first and foremost is a great idea because, as you said, it indicates what you can do subsequent to that. And it also is probably going to be brought up by your nurse if it's inadequate. So,
yep, exactly.
So you might as well address it sooner rather than later. So from a access perspective, you obviously can have a peripherally inserted IV. That's usually what kids come with. And again, I would think about this in terms of what bucket did you place this child in, right? That bucket where they're getting better, they're going to leave. Maybe they don't even need an IV, and wouldn't that be great? Although we all know that the floor team loves having an IV, but just keep it in mind that sometimes it is okay to say this patient doesn't need an IV. But that patient who's getting better and hopefully leaving the ICU soon, that patient certainly doesn't need anything more than a PIV. And then the other two groups, the groups that are critically stable or critically getting worse, you're obviously going to be talking about different types of access. In the acute setting, when you just get a patient down and they're critically ill, it's ideal to have 2 access points. And so if you only have one PIV, getting a second PIV is always a good idea. You never know when one's going to go poorly. And then it's also taking a step back and thinking about what is the duration of this course of illness? How long do I think it's going to take to get better? And that's definitely an art. Not everyone's good at that. But, if you have an intubated kid, it's going to take more than a couple of days, right? And those are kids that you're trying to keep safe with continuous sedative infusions. Or if you have a child who's on vasoactives and you don't think you're going to be able to come off, that's when you start to think about central access. So before I move any further, since I brought it up, it is a urban legend that you cannot do vasoactives through a peripheral IV. So just know that is not true. You absolutely can. But as you're titrating up on your vasoactives, the more urgent it becomes to put in a central line. There are some kids, in my experience, that need a whiff of epi, 0.03 to 0.05 for a couple of hours, and then they get better. Those kids probably don't need central access. But those kids that come down looking critically ill, you probably want to get central access on the earlier side of things. Those kids that are getting intubated and aren't going to stay intubated for a while, you probably want to get central access. And so central access, I think about anyone who needs access for more than just a couple of days. A PIV is good if you only need it for 2 to 3 days. If you're going to need it for longer than that, start thinking about central access. And you can do, there are central lines that ICU providers put in. There are peripherally inserted central lines, which often interventional radiology puts in, or sometimes hospitals have PIC teams that are nurses trained to do that. There are surgical lines. So there are tunneled catheters, we will say Broviacs, and then there are ports which are implanted under the skin and can be accessed using needles. All 4 of those are different types of central access. ICU providers place central lines, usually in the femoral veins, the IJ, or in the subclavian vein. Those are the 3 common locations for us to place central lines in. PIC lines are peripherally inserted, so they're oftentimes in the arms and the legs. And then the 2 surgical lines are often in our HEMONC population. They come to us with central access. Great. We don't have to put them in. Fantastic. Or TPN dependent expremies, right? They already have central access. But in the critical setting, if it's a previously healthy kid, then oftentimes you're talking about a PIC line or a central line. They all have pretty equal infection risks. Tunneled central lines and ports tend to have lower infection risks, which is why our onc colleagues go to those. But PIC lines and central lines that are placed in the ICU, they tend to have equivalent infection risks. So there's really no difference between those 2. There are sometimes hospital protocols, like for example in DC, if it's an ICU placed central lines, those cannot go to the floor because the floor nursing teams do not know how to do appropriate care for those lines to prevent collapses. And so those lines have to be pulled. So if this is a kid who has a difficult access, who eventually will have to go to the floor, you might consider a PIC line in that child for that reason, right? Not because you can't place a central line, but because even outside of their ICU, say they're going to need somewhat temporary but prolonged access. And so a PIC line is more important for that. So those are the different types of central venous access that we have, and different reasons why you might have one over the other. And then the other types of lines that we often talk about are arterial lines. And those are placed in patients who you need continuous blood pressure monitoring. So someone who may be hemodynamically unstable, someone who needs frequent lab draws, and is a difficult stick, or someone that you're concerned about their respiratory status. So you want to get the best indicator of their oxygenation, which is PaO2 values. Maybe they're septic shock patients and you want to be able to sample arterial lactates. That's another reason. And so those are reasons why you might have an arterial line. Don't worry, your friendly ICU bedside nurse will tell you what kind of access they want / need.
Yes. It will be generally asked for.
Yeah.
But yes, knowing what lines and tubes your patients have is really important. What lines and tubes they don't have but potentially need is important. And you can include that almost before you go by system. So when you're giving your assessment, when you say what the patient is there for and whether they're getting sicker or not, you can say current access includes, and then what you would recommend, right? The current access includes 2 PIVs. And if you're presenting before your nurse and you know your nurse wants one, you can present, maybe we should consider a central line, because then the nurse is like, yes, that's on my side.
Next level thinking.
Exactly. So, I think that's good. And then also thinking about if you do have central access, when that can come out, because all of the lines and tubes we put in are sources of infection. So Foley's should, it's very rare that we need a Foley. Pull the Foley
as soon as you get it.
As soon as you get it, pull the Foley. No, there are some reasons why you might need a Foley, but as soon as you can possibly pull the Foley. And then if you don't feel like you need central access, so all of those things we talked about why you might need central access, if that's reversed, the kid's getting better, they're extubated, they're going to the floor and going to be discharged soon. All of those reasons might be why you might pull your central line and get that out as a source of infection. If you're not doing frequent lab draws anymore, take that arterial line out. If you're not monitoring PaO2s anymore, take the ART line out. So whatever caused you to put it in, the moment that is no longer true, talk about taking it out to reduce the risk of infection.
That was the perfect segue, I think, into the last piece of this, which is talking about dispo for your kids on cruise control, so to speak, for your patients who you're not doing too much for. How do you start to think about transferring them to the floor? And of course, the mechanics of this do vary, of course, institution to institution, but big picture, what are the things that you look for?
Yeah, I think that's a good question. And like you said, I think it is very important to know your hospital policies. And anytime someone tries to hide behind a policy, just ask very politely to see it, because I find some of that is urban legend.
Urban legend! That's amazing.
Yeah, could I just see that protocol? It's really interesting. This happens in every hospital.
Yes.
It's so common for people to be like, well, according to the policy, this has to happen. And you're like, what policy?
Where is it?
Which one? Is that true? Or is that just urban legend? So make sure you're confirming policies and what's actual policy. But, you want to do what's best for the patient. And I think a lot of hospitals are feeling that these days there's a lot of tightness on floor beds. There's a lot of tightness on ICU beds, especially in the pandemic. I can just say personally, our hospital and a lot of our area hospitals have been on divert because we're just full. And so you're going to constantly feel this pressure. You don't want anyone not to have a critical care bed that needs it. And so as kids are getting better, you're like, well, you don't really need me. And this patient really does. So you're going to feel that pressure to try to move kids out, but know that you never want to do that prematurely. Right. So here's how you can think about it. Are they at their neurologic baseline? If the answer is no, do not pass go. Right. Keep them in the ICU. If they're not at their neurologic baseline or their new neurologic baseline, which happens sometimes, right? Like let's say a kid comes in with a TBI, they're obviously not going to get back to their baseline in a short period of time. But if they're at what you would consider a stable baseline for them, that's okay. That patient can continue on. You can continue on. What amount of respiratory support are they on? And for me, I don't like to send them out on the maximum respiratory support that the floor can handle, right? Because
they will bounce right back. If anything happens,
Because these kids can go up and down. You know, kids who have been in the ICU, you tell the parents they're running a marathon, 2 steps forward, 1 step back a lot of the days, right? And as long as you have forward progress, that's good. So if that remains true, even as they're leaving the ICU, so you want to make sure that even if they take a small step back, that the floor has room to treat that step back. So making sure that their respiratory support is at a level that the floor can handle and that they have room to escalate before calling you. CV wise, this kind of should have been said first, but if there's any hemodynamic instability, do not pass go. Keep them in the ICU. And those are the 3 main organ systems that I'm thinking about. Am I providing any kind of intervention in those 3 organ systems that can't be done on the floor that require my level of expertise? And then other things are really important. How much nursing care does this patient require? Maybe they're on their baseline trach collar, but they're requiring Q1 hour sectioning. Right. Floor nurses do an amazing job, and they do it in multiple patients, and they're pulled in many different directions. And so being mindful that if you're sending a kid out who requires close nursing care, then they're just going to bounce back as well. And making sure that the therapies that you are giving when at the time of transferring them out are things that can be maintained on the floor. If a child needs chest PT Q2 hours, that's really hard for a respiratory therapist who's given 20 kids to take care of to maintain. So knowing what your floors are capable of is a really important factor in that decision, but also that the patient's trajectory is overall improving and that they've hit a couple of the checkpoints that means that they're safe to go out.
Wow.
So I'm sure I've forgotten something.
No.
I think that the thing that I love the most about your DISPO criteria is the one step below the maximum floor respiratory support, because that's why we transfer asthma patients who are on Q2 hour albuterol, even though we accept continuous albuterol on the floor. They need to be able to wiggle room.
Yes, exactly. Yeah.
I find that when kids come out, the minute they are floor stable, everybody who accepts them is on high alert. And I almost think you're more likely to like trigger maybe a premature RRT, just, the first hint of discomfort, like clinical discomfort with the patient, it's like, go back. So if you have no wiggle room whatsoever, I think you are setting yourself up for just not a good transfer of care and likely a bounce back. And that's the thing. It's like everyone needs to be, the accepting team needs to be on board. Nobody wants a patient who's in the ICU who can come out to stay there for a minute longer than they have to. And nobody wants someone who needs an ICU bed to not get one. But it's such a difficult thing right now, especially with the censuses being so high.
And now we're just going to take a quick detour here to discuss discharging home our patients who have home respiratory support. So for instance, if they are trach vented or if they have home BiPAP.
These are more like resident things to think about, but I feel like that's next level. Take it away if you'd like to.
All right. So you must ask yourself, are they on their home bed settings?
Exactly.
Do they have their home respiratory support at bedside? And by that, I mean home BiPAP, home CPAP. Has it been checked by biomedical engineering? And then I've heard some people say, and I know that there are a million variations of this, just because it's stable vent settings on a Tesla doesn't mean when you move it over to a Toyota Camry, it's going to perform the same way. And so having them on that home servo or whatever it is.
Yeah, absolutely. That's important.
Before discharge is nice and probably crucial.
Yeah, I think that probably different institutions have checklists for this because I feel like the only way I learned any of this was because of checklists and RTs and nurses telling me, oh, they're not ready because you haven't done these 5 things that need to be.
Yeah, no, exactly. Yeah. It's not, as the resident, you're not going to be the lone advocate of this, but
you have to think about all of it. So it's super important. And then of course, like the logistics, I think of any time you're discharging somebody out of the ICU, it's a little bit stressful because you have to kind of do the home care thinking. So just making sure that that's on your list. This has been such a journey. I feel like 2 years of us. Yeah, it's amazing.
And broad. Thank you so much.
Oh my goodness, it's been my pleasure. I'm glad. Hopefully I didn't put anyone to sleep.
No. Oh my gosh. It's all high yield.
Excellent. Happy to be on the podcast.
We have a closing question that we ask all of our guests, which is either what is your favorite thing about being an intensivist, or what is something new you learned or something you learned recently that you can't get out of your head?
Oh my. Well, I learn something new every day, which is probably what I love about being an intensivist.
It's a hybrid answer. I love that.
Hybrid answer. Yes. No, I love being an intensivist because I love the fact that I can help families and patients when they're at the worst moments of their lives. And most of the time, kids get better, and I can have an impact on that, and I can help guide parents through that. And so I love that about being an intensivist, and I love the fact that I can see kids get critically ill, and because of my interventions, they get better. And in the small population where that's not the case, where they don't get better, I can help guide parents through that process with dignity and grace. And that is an incredible gift, although emotionally draining. So that's what I love about being an intensivist. And what I love about it being an intensivist who educates is watching the people I train connect the dots and have the light go on and say, I get it now. And so I love doing that too.
Wow, that was amazing. Thank you so much. Really amazing. Come back all the time.
Anytime. Talk about anything and everything we can get.
Exactly.
I'll have more pearls. I have more chloride is the devil's ion. I have more tag phrases. Don't worry.
This is just the beginning.
Wow, Shefali, that was just such a great conversation.
It was such a great conversation. Thank you guys for sticking with us through this journey. We hope you found this as valuable as we did. We honestly think this will be a game changer for presenting the ICU, just remembering that it's okay to feel uncomfortable. It's a different environment than what many of us are used to, and that there is a way to break it down to sort of, I think, optimize it in terms of your learning and also, how clearly you're communicating to the rest of the team and the family.
Yes. Please let us know at PedsCritPodcast@gmail.com what you thought. If I love these intro episodes, but if they hit different, let us know. We can change it. We're on Instagram. We don't recommend following us on Twitter. And we'll see you next time.